Welcome back. So we'll continue with basics of polysomnography and sleep stages. So you've already gone through the animal sleep EEG patterns, and from yesterday you have already seen some EEG patterns that are specific to humans. So I hope it's getting slightly clearer. Across species too, there are features which are common and can help in determining which stage the person or the animal is going. So in this talk, I'll cover under 4 headings. So initially, I'll give a brief account of what polysomnography is, PSG is, and then few tips and understanding of how the measurement is done. And once you have the measurement, how to evaluate it, and some useful information that you can gather from all these recordings. So fundamentals, polysomnography or PSG, what is it? So as the name suggests, poly means multiple. So it's a measurement of sleep using multiple physiological parameters. And there will be so many wires, sensors connected to a subject. And these will result in various time series recordings. So these graphs where there are values which change across time, they are commonly called time series. And here in the top part, the time series represents EEG signals or brain signals. The next one is eye movements. LOC means left outer canthus or left eye and right eye. Then the red traces relate to muscle activities. Usually we have one muscle measurement. It will be usually the chin muscles for sleep staging. But you can also use muscle measurements from your leg or hand based on the assessment plan. Then you can also measure respiratory parameters like the amount of snoring using a microphone or a vibration sensor. Then you can use pressure or temperature based measurement of nasal and oral airflow to measure whether breathing is stopping or is it same through nose and mouth. Sometimes, though not normally practiced, if you want to study nasal cycles, you can have 2 different independent sensors for left and right nasal cavity. Then there are these bluish traces correspond to effort sensors to see whether the muscle activity of chest and abdomen are happening properly, thoracic and abdominal effort sensors. And there could be some of the devices can also calculate from multiple waveforms and then create a single waveform corresponding to whether breathing has happened or not. Individual ones are sometimes required if you want to know whether it's an obstruction at the nose or tongue or mouth level, or is it because of muscle disturbances. Sometimes even discrepancy between chest and abdomen may not be in sync. Then oxygen level, heart rate. So multiple physiological parameters can be measured, and this kind of measurement is called polysomnography. And from such a measurement, one of the key aspects that we take is to identify the sleep stage. And sleep stages are plotted again as a time series. But here, for every 30 seconds, we identify what the stage is. And across minutes or hours, we'll get this pattern. And this pattern is called hypnogram. And a typical representation is wake will be at the top, paradoxical sleep or REM will be somewhere in between, and the NREM stages across depth, like NREM 1, 2, 3, will be from top to bottom. And in many graphs, the REM, to highlight it differently from N1 or wake, it will have a thicker bold line. But there are various representations possible with this graph. As I mentioned, sleep stage, the depth of sleep stage comes down. The only paradoxical part is REM is also a deep sleep, because of which in some representation REM will be put below N3. Now, this same information can be obtained even through fitness trackers like wearables that you have, or mattresses or mats which can be, you don't need to wear, you just need to sleep on top of that. And there are even non-contact devices which can detect based on your activity or breathing pattern, or in combination, they can identify the stages. So in that way, these are also polysomnography measurements. But as Dr. Ravi Gupta mentioned earlier, there are the gold standard still remains to be polysomnography in a lab, but these give you measurements which are much more accurate than subjective reports, and can be done across a large population. As we know, sleep issues affect many people. Now, historically, the earliest kind of attempt to discriminate different sleep stages happened in 1935-39 period by Loomis, Harvey, etc. So they divided NREM stages, because at that time REM stage was not identified. So they had 3 stages based on the depth of sleep, and later based on this sleep clinics or sleep labs, research labs started to identify the depth of sleep. But then Aserinsky and Klipman kind of identified or discovered REM sleep from animals, and from then the classification of both, including both NREM and REM, happened. But in 1950s, a consensus started building up, and proper clinical sleep disorder clinics started to be formed. 1967, a standard criteria was kind of formulated by Reshoffen and Kales, which is popularly known as RNK scales. Though it's currently not widely used, still there are labs which continue to use this scale. And since 2004, we have American Association for Sleep Medicine, which has been giving the guidelines for sleep staging. Now, annually they revise the scoring criteria. So that's regarding the history of sleep stage classification. And now recordings were done primarily with sensors placed on the scalp and elsewhere. And all these sensors will be connected to a junction point, which is called junction box or a head box. And they will be connected to the device, which in the early days, they were directly writing on a paper. So they are called analog devices. And based on the number of sensors you have, the height of this device increases, because each of this horizontal unit is involved in recording one single waveform. But now the things have changed at the recording end. So now we have laptops and desktops which can record any number of sensors, and the amplifier is as small as a it's pretty small now. But at the recording site in clinic, it still remains almost same. We could even use the old records for many of these devices. There have been improvement now. Now there are dedicated caps which you can use specifically for sleep, which means the placement will be easier now. So you don't need to identify the places, and across lab, the measurements will be more consistent, and it's more compact too. The cables are all embedded into a single connector, and you don't need to individually place it. Okay, now I mentioned at the beginning that polysomnography is a measurement of so many physiological parameters, but all these physiological parameters are not required for identifying sleep stage. So if you want to identify sleep stage, and that is your primary motto, the basic polysomnography setup should consist of at least 3 physiological measurements. One measurement is with regard to brain activity, which we call electroencephalography or EEG. The second measurement is regarding the eye movements, which is called electrooculography. And the third one is related to muscle activity, and usually it is measured around the chin, and this is called electromyography. So with these 3 physiological parameters, anyone should be able to accurately score sleep stage. So all the sleep staging criteria are based on these 3 measurements. And upon that, if you want to study respiratory parameter, you can add that, but that has nothing to do with sleep stage scoring. If you want to study cardiac parameters, you can have BP and heart rate measurements. If you want to study other muscle activity, behavior, etc., you can have. If you want to record the entire behavior, you can have video cameras. If you want to quantify, measure the amount of what the subject speaks or says during that period, you can have microphones, but they are not directly to do with sleep stage. So in terms of brain activity, what we measure, in fact, all these measurements, all these 3 measurements that I mentioned are voltage based. So that means the device is trying to measure what is the voltage at a period of time. And the device usually measures hundreds of times per second these voltages, so that you will get a profile of the change in voltage. So that's what we are seeing, voltage difference across time. And it is actually voltage difference. That means, and the voltage is very small in the brain signals, and sometimes even eye signals are in the range of microvolt. And that is like, say, 10,000 times lower than a volt level. So many devices require the signal to be as in a slightly higher range. So you need an amplifier to increase the signal to a level that the device can now start interpreting. So that's why we need an amplifier, and the amplifier alone is not enough. We want to take the difference between 2 different sites, because the whole body undergoes change in voltage. But if we want to study the brain activity, we need one reference site, which usually will be around the ear or behind the ear, called mastoid. So that's a reference site. So whatever whole body voltage change happens will be captured by this. And the site where we want to measure, that will be called the active site. So for example, I want to study this vertex region of my brain, there what is happening. So that will be my active site. So I will always compare my active site with my reference site, and the difference in voltage, that will be amplified 2000 to 10,000 times, and that will be converted to a value. Now the problem is, this voltage difference could be anything. It could be a positive value, negative value. We do not know. For that, we need one more level of reference, and this reference is to do with the amplifier. Because any scale you take a weighing machine, the weighing machine should have a 0 calibration. It should know what is 0. From there only it can be higher or lower. So that reference is usually given by one more sensor, which is called ground. It's called isolated ground because it's different from the power ground. The power socket also has a ground point. That is to do with the leakage of electronic devices. Whereas this ground is only to do with our EEG electrophysiological measurement. And this ground will tell the amplifier based on which site it is coming from. Now this is my average voltage. So compared to this, if this difference that we calculate is higher, it will be a positive value. Compared to this ground, if it is a lower value, it will be a negative value. So with this ground, we know what is a 0. And now if you record, every time this ground also will be recorded along with this active and reference. So now each time you will know whether it is positive or getting more negative, getting more positive, negative, etc. And this is usually joined together by lines and plotted as a wave. So this is what you finally see, but the underlying mechanism is voltage differences being acquired across time. And then the rate at which we measure this voltage per second is usually called sampling rate. Usually higher the sampling rate, better, means the more faster activities in the brain can be captured well. And now once we measure, one of the features that we identify from the waveform that we measure is called frequency. That means this wave will go up and down, means positive and negative, so many times repeatedly. And so how many times it repeats per second, that component is called frequency. And normal EEG or brain signal will have multiple frequencies. So each frequency has its own biological meaning. Some of them I'll relate later. The second parameter that we would be interested in is the height of the wave, which is in terms of amplitude, or if you square, because amplitude means it can go positive or negative. And positive as well as negative, both of them imply so much amount of brain activity. So the sign may not be very relevant in many cases. It is usually the height which is more important. So if you square it, so you will take into account both negative and positive. So if the negative part is going larger than positive, if you take the square, that will also be accounted. So power is many times used as a better measurement for evaluating this. So now coming back to the frequencies, we have delta, which is less than 4 hertz, theta, which is between 4 to 7 hertz, alpha, which is 7 to 12 hertz, beta 12 to 30 hertz, and gamma, which is 30 to 50 hertz. So these are common not only for humans. You already heard in the previous talk, in animal studies also these parameters are there. And one of the thing you can observe here is as the frequency decreases, as the frequency increases, the amplitude, the height of the waveform actually decreases. This is one of the reason for this is because the signals, when it traverses, the low frequency thing can travel across the skull effectively, because of which its amplitude retains. Secondly, low frequencies are so low that even nearby regions, they get added up, they can get synced. That's why in a room, if somebody does a choir, that the group kind of singing will be loud enough to be heard far off, but the fast utterances will not be heard outside the room very well. So fast utterances are similar to this gamma, so they will not come out of the skull very well. So that's one of the reasons why these signals are smaller, and the low frequency ones are usually higher. Now, based on these frequencies, we can stage. So this is a small snapshot of the hypnogram that I showed earlier. So in terms of frequency, this is how it looks like. Our brain signals are never composed of a single frequency. So what we look is what is the predominant frequency in the waveform. So if the predominant waveform is something like this, which is small, mixed, and little fast activities, if you quantify, it will be in the range of beta. That means more than 30 hertz. More than 13 hertz. So that means the brain is mostly in the NREM light stage, NREM 1, or sometimes even wake. So if you are in NREM stage 1, you will have both this beta kind of activity as well as alpha, but alpha will be less. If you are in NREM stage 2, then you will have slightly slower activity with intermittent fast activities called sleep spindle. If you are in NREM stage 3, you will have this predominantly large and slow waves called delta waves. And in REM sleep, which I'll be showing later, it will be a mixture of many of these parameters, predominantly the mixed higher frequency. So that's a general overview. If you look at a single waveform from the brain, you will see, and usually we look at a 30-second window to see. And this will be described subsequently in more detail. And in N1 it becomes smaller, and in N2 you can start seeing some small slow waves, but predominantly it is slow, and some fast activities called spindle. And N3 is much more clear, and REM it is mixed. Now, the same principle of voltage difference can be used to identify eye movements too. And this is because eye is also an electrically active thing, because the retina, which is at the back of the eye, is electrically active. The signals go off through optic nerve. The front part of the eye, called the cornea, there no major neuronal structures are there, because of which that's actually electrically neutral. But just because all the electrically active neurons are placed at the back, and because the signals are going away, it is usually negative. So the opposite end, which is cornea, automatically becomes a positive end of the eye. Now, this is a highly positive region. And if you keep a sensor, even though it is close to the scalp, but it is close enough to the eye, whenever the eye moves towards that electrode, you will start seeing a positive deflection. So for this eye, the eye moved towards this electrode, so it will go in the positive direction. Now, for the other electrode, this eye is moving away, because unless you have a squint, both the eye will synchronously move. So if this, say, right eye is moving towards the right side, the left eye will also move towards right side, because of which it will move away from this sensor. So moving away will cause it to have negative. One of the reasons is the negative end of the eye, the retinal end will be closer to that particular electrode. So that's why in the deflection you will see right eye going positive and left eye simultaneously going negative. This means that whatever activity you saw is because of eye movement, and that is confirmed only if you have sensors around right as well as left eye. So that's why in polysomnography you will have to record from both left and right eye. And no eye movement, it will be flat. If it goes in the opposite direction, it will again be different. Now this is EOG. So based on that, if eye movements are rapid, you can see this kind of measurements, and these are seen in rapid eye movement, sleep and wake. Sometimes the eye will be slowly moving, called rolling eye movement, seen in N1 stage, and sometimes the deflection will be in the same direction. This typically happens when you are blinking, because in blink, it is not because of eye movement, it is because of eyelid coming on top of the eye, and the eyelid becomes positively charged. Because eyelid becomes positively charged, the nearby skin will also be positively charged. So both left eye as well as right eye will start seeing a positive deflection. So if you see sharp positive deflections in both the eye, then it is blink. If the sharp deflections are going in the opposite direction, it is because of eye movement. And eye blinks occur only when you are awake and eyes open, but eye movement can occur even if you close your eyes and even if you are in sleep like REM stage. A muscle activity, again same voltage principle. Muscles are also electrically active as like a neuron, and their activity is much more stronger, so it will reach almost like 100 microvolt signal, and they are mixed and they are fast compared to, because they are on the surface of the skin, whereas the brain activity is happening under the skull, because of which only the low frequency components we can appreciate well. Muscle activity will be dominating all the high frequencies, like after 10 hertz to 100 hertz, all that spectrum frequency activity will be usually muscle. And you can appreciate it better when you place sensors around the muscle region like chin. If you place on the head, there will be minimal activity. There are muscles around this forehead region and temporal region. So sensors around that may also pick up some muscle activity. So if you are awake, the muscle activity will be like this. Once you enter into sleep stages, it will become smaller. And sometimes when you move, suddenly muscle twitches and comes back. Now, based on all this information, you will have a pattern specific for wake, for N1, N2, N3, and finally REM. So these will be covered later, so I'll not go into details much. You can also measure ECG, and there are patterns like irregular heart activities can be seen during REM. You can look for respiratory parameters where the breathing stop period, like apnea, can be measured. Even some people, for studying emotional surges or activities during sleep, people study GSR activities or even autonomic response. Now, measurement. Again, there will be a tutorial video on this in detail, but basically you need a sleep chamber, the amplifier, and a device to acquire. And usually you'll also have a video camera, and the subject will be covered with electrodes. And you need to look at several aspects regarding sleep lab. For example, the space should be adequate. It should not be filled with equipment so that the subject will be uncomfortable. There should be access to restroom, because many subjects would like to go to restroom just before, after connecting all these electrodes, and sometimes in the middle of the night too. And sometimes after getting up, it will be easier if the restroom is nearby. And in case you're studying any medical condition, then access to medical health emergency facility would be required. Hospital-like environment would be one case, but the problem is, if anybody who have spent time in hospital, your sleep will be completely deranged in such an environment because of the noise and the occupancy. Hotel-like environment is an ideal setup, but it's very costly. And many times we have to resort to somewhere in between so that the equipments are minimized, the environment looks calmer. Other than amplifier, most of the equipments can, like PC and in it, the power unit, etc., can ideally be shifted outside the room so that the subject can monitor without interfering the sleep of the person. And the electrode are placed based on 1020 system, which will also be covered during the demo. So the electrode placement is based on 1020 system. ASM guideline specifically for sleep describes more on the placement of EOG and EMG and specifies among this 1020 system which are the electrodes to choose. So typically at least one of the frontal, one of the central and one of the occipital electrodes are required for sleep scoring. Rest of the electrodes could be used if you are more interested in brain activity. Otherwise, only these 3 electrodes are enough. And you could have one pair, one of the means all the 3 on one side as the main recording one, and the other 3 can be used as backup. Similarly, for eye also you need one eye which is for right and one for left. That is enough. And usually it is placed obliquely. For example, right on top and left below, in such a way that both vertical movement as well as horizontal movement can be picked up, because we are not interested in knowing whether it is vertical or horizontal. And as a backup, you can also use lower right and upper left. So in case one of these electrodes go off, you can use the other pair, again oblique. Muscle also, you usually need only one pair from this part of the chin to the bottom part, but you will use one more extra EMG as a backup. Now sensors. So this is the typical setup, where you need an electrolytic paste to conduct between the electrode and the skin. And to prepare the skin, you need cotton and gel. And you need a measuring tape to identify the right locations, adhesive sensors, especially for ECG, and the electrodes. There are additional sensors like for nasal airflow, which is a thermistor, snore vibration sensor, and the effort bands, which are placed around the chest or abdomen. Now, preparation. First would be to measure the electrodes. So 1020 system states that you need to have landmarks like the nasion in the front, the enion in the back, so that's a black mark one, and tragus around the ear. So these tragus will be on both sides. So you will have 2 left and right tragus region landmark, and front and back you have nasion and enion. So 4 bony landmarks are there for you, with reference to which you are placing the electrodes. And 1020 system, the first electrode from the landmark will be 10%. All other electrode will be 20%, 20% apart. So based on this, you place the electrode. And once you identify the location, you clean that region and put an electrode paste. And the electrodes are placed. This will be covered more in detail later. And you will anchor them either using a gauze piece, or you can use electrode caps, which will be shown in detail today. And once these electrodes are placed, you can start placing the other sensors like respiratory bands here. And for limb movement and nasal airflow and snore, you can place sensors. And you need to check whether the electrode placements are correct using a measurement called impedance. And after that, you can check whether the electrodes are placed properly, and the subject can go into sleep. And once the subject sleeps, you can, and the recordings are done, then the visuals scoring is required. As I mentioned, 30-second windows are used. You need 3 signals from the brain, occipital, central, and frontal, 2 from eye and 1 from muscle. And a typical window of wake looks like this. NREM stage 1 looks like this, N2 like this, and N3 like this. So this will be covered in more detail using a continuous recording. REM stage is looking like this, and besides the EEG is less helpful in identifying REM, but rapid eye movement and low muscle tone will be more confirmatory to identify REM. And in between sleep, though this is not a sleep stage, between stages, transition might occur with movement. During movement, the waveforms will not be interpretable. So we look at the previous window and later window to determine what stage it is. And there are stages which occur for less than 15 seconds. Those kind of wake-like activities are called arousals. They are not considered wake stage. Blinks again during wake. Now, from all these parameters, you can look at the total sleep time, total time spent in bed. In that, the sleep will occur after a latency. That is called sleep onset latency. And latency is usually from N1 or N2. So in some literature, just one episode of N1 is enough to call that sleep has started. But in many other cases, N1 is very unstable. So after N1, you can go back to wake for very long period. So stable, say, at least 2 minutes of N1 might be required. Otherwise, at least one N2 stage or N3 stage occurs. That means you have started to enter sleep. That will be the start of the sleep. So from the start of the sleep till the end of the sleep will be total sleep time. And the onset, when did the first REM occur? So those kind of parameters can be looked at. The overall, take only the N3s and add up what is the duration in minutes or percentage, REM, etc. And then wait. So these are the standard parameters recommended by ASM, of which one of the thing is out of total sleep, out of the total recording time, how much time or did you sleep? So that is sleep efficiency index. And besides sleep measures, you can also look at arousals and others, which will also be described in more detail tomorrow during OSA presentation. So normative data suggests that across age, the total sleep time decreases. With age, the sleep efficiency also decreases, wake decreases. REM is also sometimes decreasing. Usually it is stable between, say, around 10 years to 60 years. It will be relatively around 20 only. But slow wave sleep dramatically decreases with age. And the measurement that I mentioned, which happens during lab, is called level 1 PSG, which means it occurs in lab. A technologist is required, breathing, snoring, respiratory rate. In addition to EEG, all these measurements will be usually done, and it helps in diagnosing sleep apnea, syndrome, narcolepsy, REM sleep disorder, etc. Now, there are other levels of PSGs. For example, if you want to do a similar setup with EEG, but at home, there are devices, they are called level 2. Whereas if you use actigraphy or, if you use measurements which look into breathing pattern alone and not into the EEG, they especially useful for OSA titration, etc. That is called level 3. And all these things are based on sleep medicine targeting only the breathing related disorders. So if you still need brain activity or activity like actigraphy, and there are even much more portable EEG devices. So they also probably come under level 3, but they are not usually classified as such. This level 1, level 2, level 3 is usually a classification targeting the sleep apnea evaluation. So as I mentioned, there are now EEG devices under 50,000 which can be used for sleep measurements and are consumer grade. So you can do this across hundreds and hundreds of people and get compiled results. Now, PSG measurements as such. So from the hypnogram, you can know the sleep onset is long in some insomnia cases. You can have broken repeated awakenings in some maintenance disorder cases. During sleep onset itself, REM can occur in narcolepsy. And other information. For example, even if you have a basic measurement using actigraphy, you can identify the sleep onset and offset. And studies have found that this sleep onset and offset corresponds to melatonin peak. So this can be an indirect measurement of your hormonal status. And there are mental disorders like schizophrenia where this whole onset, offset, and melatonin that is severely affected, especially if you look at the variation in offset across multiple days. So 1 or 2 weeks of continuous actigraphy measurement can give you a good insight of their circadian abnormality. And from the hypnogram itself, you can specifically look at each cycle separately because they themselves are asleep of their own. So there will be abnormality specifically to one particular cycle. And sometimes within a single 30-second window, you can see transitions between NREM to REM to NREM to REM, which is a sign of neurodegenerative condition like Parkinson's disease. And the activities, the EEG events, which are called spindles, they themselves can have different profile in disorders like schizophrenia, Parkinson's disease, depression, etc. And they have a profile across sleep cycle which can be used to identify deficits. And studies have found that the deficits in this signal occurring within sleep have a relation to the size of the brain region like thalamus, and probably its interaction with cortex. So there is much more to do with polysomnography. It's a multidisciplinary field. People from pulmonology, from neurology, clinical, non-clinical engineering, animal, every field contributes to sleep. And there are huge amount of patterns in sleep which is still not fully understood. So as I mentioned last day, these are two books that I would recommend if you want to understand sleep medicine. And thank you for your time. We'll have more detailed session on sleep scoring and sleep recording coming up. So yeah, so wait for it. Thank you.